Hi, my name is Mark Fulcher and I'd like to show you how I examine a lumbar spine. Before we have a look at Jesse's back though, I'm going to ask him to do some walking. So I think it's important to have a look at the patient's gait. So Jesse, if I could get you to walk a few steps away from me and then turn and come back. So basically this is to see whether the patient has any issues walking, whether they have an antalgic gait, whether there's any evidence of a foot drop or any problems that might reflect weakness or pain. The other thing I like to do with the patient standing up is to have a look at their ability to heel and toe walk. So if you can get up on your tiptoes and do some walking, so that's a good screen for the S1 myotome. And then if we get you on your heels and do some heel walking, this is a good screen for the L5 myotome. So no problems walking on his tiptoes or on his heels. So we're thinking that his power is grossly normal at this point. It's important to have a look at the lumbar spine. So we're going to ask Jesse to take his shirt off. Patients with lumbar spine pain are often very uncomfortable, so simple tasks like taking your shirt off can often be quite sore. So it's useful to keep a close eye on how they're moving and how things are working. I'd like to have a look from side on. So if we get you to turn side on to the camera there, Jesse, we're having a look at the normal lumbar lordosis. And so patients who have a very painful low back, they stand quite erect and they lose that normal lumbar lordosis. We get you to turn facing away. You need to have a look at the lumbar spine in its entirety. So we're having a look down through the midline, having a look to see if there's any evidence of a scoliosis. Patients with discogenic pain will often have a shift. And so we're having a look at the overall alignment. We're also having a look, sometimes you can see a lot of paravertebral spasm. So the muscles are very tight and they look rock hard and solid. And that just implies that the patient may be in some pain. So everything is obviously fairly normal here today. Having inspected, we're going to have a look at Jesse's range of motion. So if we get you to turn side on again, Jesse. First range of motion I'm going to have a look at, I like to be sitting down behind the athlete, holding onto their pelvis. And we're going to ask Jesse to bend forward, try and touch his toes, keeping his knees straight. So looking to see whether he has any pain or problems with lumbar flexion. If we get to stand up tall again, Jesse. It's a good way to quantify that is to have a look at where the fingertips reach. So I'll write the athlete is able to forward flex until the fingertips reach the ground. The athlete is able to forward flex until the fingertips reach the ankle joint line. Then I'll ask him to extend his lumbar spine, so lean further back over my thumbs there, Jesse. So looking to see if he has any pain or problems. So no issues with that. I'll then take the athlete into extension with right-sided and then left-sided extension, seeing whether those movements are also provocative. In general terms, pain with flexion, I think you typically see with discogenic pain, and pain with extension, that's making me think more about a pars defect, although those are not hard and fast rules. The other movement I do with the athlete standing up is side flexion. So if you slide your right hand down your right thigh towards your knee, any pain or problems with that, and left hand down your left thigh towards your knee. And then again, I document that based on how far the athlete is able to get their fingertips down their lateral thigh. So normal, I think, is around about the knee joint line. So I'll document the athlete is able to side flex to the knee joint line. With them standing up, I can also measure Schober's test. So if I think there is a loss of flexion, if I'm thinking there may be an inflammatory cause of pain, then that's a useful test. So to do this test, we're going to need a pen and we're going to need a tape measure. So to do the test, we find the dimples of Venus, so at the back, and I mark those. So that's a surface landmark for the L4 spinous process, roughly. And then we measure 10 centimeters above, and then 5 centimeters below that mark. And so what we're going to do is ask the athlete to flex forward and see how much change there is in his lumbar spine movement. So as he flexes, my tape measure is moving. And if you don't get more than a 5 centimeter change, then we're documenting lumbar stiffness. So we can see that that changed through to 22 centimeters, so there's no significant lumbar stiffness there. Next thing we do is ask Jesse to sit on the side of the bed. So in this position, I think that's a good opportunity to test the athlete's neurology. So we can test power in all myotomes, we can assess sensation to light touch in each dermatome, and we can assess reflexes. So I think it's a good opportunity to do it with the athlete sitting on the side of the bed. We can also do a slump test, which can be a useful test in athletes that you think have radicular pain or referred pain from the lumbar spine. So to do that, we're going to ask the athlete to grab his hands behind his back and hold on to them. We're going to get him to put his chin on his chest, and we're going to get him to flex forward, slump down like he has the worst posture in the world. So then, if we're assessing the right leg, we bring his foot into a position of ankle dorsiflexion and gently straighten out his leg. So most athletes will have some degree of tightness or stiffness with this, and what we can ask the athlete to do is to lift his head up. Is there any change in his symptoms? So you'd expect an improvement if the athlete had radicular pain or referred pain. Chin back down, you'd expect the pain to come back on, and then plantar flex your foot, point your toes, you'd expect the pain to improve. So that's a slump test. Jesse, we'll get you to have a lie down. So with the athlete lying down, I then move on to do a straight leg raise. So similar test looking for radicular pain. So we're going to have the athlete lying nice and comfortable, his leg is fully extended, and I passively take his hip into a position of flexion, asking them whether that causes them any leg pain. So any pain or problems with that, Jesse? So if the athlete did develop pain, so say we're able to flex to about 30 degrees and they started to become painful, we'd say, where is that pain? They'd say the pain is in their leg. And then we would ask whether it gets better or worse with ankle dorsiflexion. So you need to be quite careful with that because this is a very painful thing to do if the athlete has radicular or referred pain. So ankle dorsiflexion we'd expect to make the pain worse. Ankle plantar flexion we'd expect to make the pain better. Knee flexion we'd expect to make the pain better. While the athlete's lying in a supine position, I think it's also a good idea to assess hip range of motion and see whether there's any evidence of a hip pathology. We can also do a figure 4 or Faber test where the athlete puts their foot on the contralateral knee and lets their hip drop into external rotation. So this is a non-specific test but can cause pain in athletes with SIJ pathology and athletes with pars stress fractures because it applies some extension force and rotation through the facet joints and posterior elements. Having done that, we'll get Jesse to roll over into a prone position, so onto your tummy. And so lying prone, it's a good opportunity to again assess the lumbar spine and have a look at the muscles around the lumbar spine. We want to palpate the lumbar spine, so if we find the level of the posterior superior iliac spines and come into the midline, that's a surface landmark for the L4 spinous process, and so we can palpate the spinous processes more proximally and then work our way more distally. So we're palpating to see whether the athlete has any tenderness. We may also note a palpable step or a malalignment at this level. And then we can come laterally, palpate the sacroiliac joints. We can palpate the soft tissues and muscles in the paravertebral and paraspinal region, which is also quite useful. Also in this position, we can do a Manel's test where we hyperextend the hip while our hand is stabilizing the lumbar spine. This is a test that's been demonstrated or documented to cause pain in athletes with lumbar spine pathology like a pars defect. So that's how I approach the assessment of an athlete with lumbar spine pathology. I start with the patient standing, move to a seated position, and then supine and then prone lying. And I think with that sort of systematic approach, you can pick up most of the causes of lumbar spine pain.